All right, Fiona, it's so nice to have you on the Fempower Health podcast. Welcome. Dr. Lara Bryden had introduced us. I know she has really great respect for you and your perspective on PCOS, and it is such a complicated condition. I've interviewed a bunch of experts, but in reading your book, preparing for this episode, I knew this would be a wow conversation. So I'm really looking forward to having this discussion with you. And because of all the great things that are in your book, I didn't want to take away from that. What I really wanted to use this time for is getting your unique perspective and voiceover on things that may not necessarily have been covered in the book. And I even took some questions from folks online and some of the PCO experts that I know who respect you and wanted to hear straight from you. So we'll cover a lot of great stuff today. But, before we dive right into this important and complex discussion, tell us about yourself.
Thanks, Georgie. And it's just great to be here because I've been following your podcast and watching it, and I'm really honored to be able to talk to your audience today. I'm a naturopathic doctor from Toronto. I've been in practice for 21 years, and I own a clinic called White Lotus Integrative Medicine. We practice primarily with women's health hormones. Especially polycystic ovary syndrome. I wrote 8 Steps to Reverse Your PCOS, and I have PCOS myself, so I'm quite interested in it. And we work with thousands of patients with this condition, so we have a lot of clinical experience with different treatments at our clinic as well.
Awesome. So, there were a lot of really great quotes in your book about how complex PCOS is. So it was really hard to come up with which one should I pick, but I thought this was a nice short one that got straight to the point, and I'd love for you to expand on it. It's that PCOS is not a fixed diagnosis, but a disorder of many faces. So tell us more what that means.
Yeah, so PCOS is quite, it changes a lot throughout the lifespan. So even in one individual, the way that PCOS presents in them can change at different times of their life or in different situations. But then from person to person, it can also vary quite a bit. So even though, we have been trained in medicine to think of it as a certain type of presentation, there's actually a lot of different ways it can present. So one of the things I find very helpful is to teach patients how to identify that in themselves to know at different times in life. And in case that they're not sure if they have it, if they don't maybe have any practitioners around them who are more focused on that, how to identify if they might actually have it, despite not having the most obvious of the symptoms expected by the medical profession.
Yeah, and tell us about that and like what really, because, I interviewed Dr. Jerry Lynn prior too, and she talked about this really being about androgen excess, but it seems as though criteria has changed over time. And as you know, even when there is criteria, you have to, there needs time for doctors to even know what that is. So getting it into clinical practice also takes time. And so I'd love to hear your perspective on where are we with the clarity and consistency around how to diagnose PCOS, and maybe we can even get into some of the misunderstandings. Like, for example, a lot of people say, oh, if you're overweight, you have PCOS, and we know there's a lot of thin people that have it. So yeah, tell us about this complexity of even just knowing
Yeah, I
whether or
think
not
a
you
lot of
have
this
it.
has come from the name polycystic ovary syndrome and expecting to see polycystic ovaries on an ultrasound. So polycystic ovaries are very different than other types of ovarian cysts. What they are is partially developed follicles, which are the eggs as they're trying to ovulate, they kind of get stuck. And then in a PCOS ultrasound, what we'll tend to see is a lot of eggs that are partially developed, and this has been given the name polycystic ovaries. So even though they're not really cysts, it has a certain appearance. Now, because of that name, I think a lot of people have taken it to be the condition. So unfortunately, you can have that appearance to your ultrasound and not have the syndrome PCOS, and you can also have PCOS and not have the ultrasound. The ultrasound is just one element that we sometimes can see in PCOS, but really PCOS is about androgen excess. So it's a syndrome, it's a hormone imbalance where there's too much testosterone and the relatives of testosterone like androstenedione, DHEA, those hormones are too high in PCOS. So ultimately, the diagnosis does include that as one of the elements, androgen excess, either clinical symptoms or in labs, which is also very confusing because sometimes labs look normal, but a person has symptoms. And then ovulatory problems. So basically, if a patient has ovulation that's more, far apart, or they skip periods or don't have periods, that's another criteria. So you basically need two of those three criteria, either the androgen excess, the polycystic ovaries on ultrasound, or the ovulatory problems. Two of those three would give a diagnosis of PCOS, but it's very controversial because a lot of people may not have the high androgens in their blood, but they have symptoms. They have the ultrasound, it goes away, comes back. So it's very confusing. And I think the Androgen Excess Society has a different set of criteria where the androgen excess is required, and either the ultrasound or the ovulatory problem is the second criteria. And I actually agree with that more. I think that's a much more accurate way of diagnosing it. The other way is the Rotterdam criteria, which are, more, it's a bit old, and there's a lot of controversy around whether that ultrasound should even be in there or not. So yeah, so it is very confusing. I always like to just simplify it to androgen excess, and we do generally see some kind of either ovulatory problem or problem with many follicles in the ovaries. So when it's sort of understood that way, and knowing that it can change in life and how it can, it becomes obvious to me when somebody has it or when they don't.
Okay, that makes sense. Thank you for clarifying. And, there's a lot of presumptions we can make in there with, it being hard to diagnose, trying to get your doctor to understand and advocating for yourself. And I would say read the book to better understand all the nuances that you share. And I think that would help educate people on how to talk to their doctor. So let's dive into some of the nuances. So first, you alluded to how PCOS can change over your lifetime. So why don't we talk about teens? Because I think there was something in your book around how just based on how teenagers, evolve up until, because I think your period doesn't really normalize until your early 20s.
So the
There
way
could
that
be
the
some
ovary sets
misunderstandings
up
of
its
what is actually
communication with the
happening to
brain
them.
and
So tell us
ovulation
about
starts. So
those
when we're children, we
teenagers.
don't ovulate. We really don't make these hormones like estrogen and progesterone in any significant amount. Once we go through puberty, the adrenals actually activate first, and they start to make androgen precursors, which can turn into testosterone. And so it's almost natural to have high androgens in the teenage years. They are the more dominant hormone first, and then it takes time and establishment of a cycle to get the other hormones to be the more dominant hormones like estrogen and progesterone. So in teens, this can take a few years to develop. And what we see a lot of the time, unfortunately, is that, it is normal for teens to have higher levels of testosterone and androgens. We always see acne. This is very common, and this is part of why. But unfortunately, what's been happening now is that a lot of teens are, having their first period, and maybe they're not having their next one for a few months. They go to the doctor, they get an ultrasound. And if you take many many teenagers and you give them a pelvic ultrasound in that phase, a lot of them look like they have polycystic ovaries, but that may completely go away as soon as their ovulation establishes itself. So unfortunately, what's happening is those teens they're getting, diagnosed with PCOS based on having things like acne or delayed cycles, which could be normal, and then seeing the ultrasound, then they're put on the birth control pill right away. And that's what's happening a lot. So it's quite controversial. In teens, they really have to have strong symptoms, and they have to be persistent in order to diagnose a teenager with PCOS. And there's a lot of movement towards making sure they have all three criteria and that everything else is excluded. Like it's not part of their normal puberty process that this is happening. So it is something that should be kind of hesitated around when we're looking at a teen before diagnosing it.
Okay. So I guess I'm just, it's funny. I'm thinking about how one may think as a teenager and just how sometimes very siloed medicine looks at things. And part of it, I just recently interviewed somebody on acne, and I think that episode's going to go live after this one. So for those of you listening, stay tuned for that. But it was really interesting because, the hormone imbalances, gut health, all of these things can contribute. But like I could also see now there could be either you're going to your derm because of the acne, or you're going to potentially a primary care doctor, OBGYN, and you get quote unquote misdiagnosed with PCOS. So you probably will get put on birth control and you have this acne. You think it goes away, but there's another root cause for acne that could be the gut microbiome, the hormone imbalance. Like it's a hot mess. So if we were to take that as a case study, right? Like, what is the ideal way to
Yeah,
handle
I
that?
think
Like, I'm
I
a
think
teen,
it's
I've
really
got
just
acne.
about
My
helping
OBGYN
patients really
said, "Oh, PCOS,
understand
take birth
that
control,
this
done. Yay, my
is,
acne's
something
on."
that can
Like,
happen in this age
that's kind
group.
of
It
an
is
overly
normal to have high
simplistic way where I
androgens.
would imagine
It doesn't
something might
necessarily
evolve. So
mean that they
what's
have
your
PCOS,
comment to that?
and there's, many other options, but birth control is an option. And I think the only problem becomes when we just like quickly diagnose, give birth control, and the person's on that birth control for 10 years. Really, we have no idea what they have and if they do have PCOS or not. And they
Okay.
come off of that and they're like, I have PCOS, and maybe they don't. So I think it's really helpful to really understand what are the patient's goals, what are the pros and cons, but just so that they understand that they may not even be able to tell if they have PCOS until some time goes by. So the treatments could be customized to that. Um, and I think the problem becomes when the patient thinks that they have PCOS in their mind, they have it, but really it's hard to say. So, you are bypassing that root cause. And with acne, some of the root causes are immune and gut and inflammation and all sorts of things. Now, if we shut all the hormones down, acne will get better because hormones are just one of the triggers for acne, but there's many patients who have high androgens that don't have acne. So there is a predisposition that has to be there to acne as well. So it's really about like understanding the individual person, but also for some people, maybe that is the best way for them and the treatment that works for them. So I think as long as the patient understands and has that really good, like, comprehensive look at everything with their case, this can be handled completely differently.
Okay. Thank you for clarifying. Now, I don't know if there's a nuanced additional
Yeah,
answer that
so
you would
this
want to
is like
share,
a
but
good
this was a
question.
specific
I can see
question that I had
sometimes
received when I posed who
online
wanted
there's a lot of
what people
different
might want to
information
ask
going
you.
around, and
So
it
it was
spreads
around
like
stress at
wildfire,
puberty
unfortunately,
activating
and
the
sometimes it gets a
HPA
bit out of
axis
control. So something that's like a
triggering
small little nugget of
PCOS.
data that we might have seen in one
So
study
any
can now
additional
become
comments
blown
to
up
that
into something that
specific
it's not.
question?
So I've seen some information online recently saying that, okay, stress is what causes PCOS. Like it's only caused by stress, and if you would deal with that, everything would be better. That's actually never been shown to be true. We know about epigenetics and PCOS, and that certain times in our development, we're more susceptible to developing changes that will affect our glands and our hormones for our life. The top time that that can happen is actually in utero when we're developing as an embryo, because there are certain timings that the ovary develops. If something happens at that particular timing, it's been shown that this can cause PCOS. In animals, for example, they can actually cause PCOS by giving an animal this endocrine disruption at this specific timing of window. Puberty theoretically is another timing for this because there's a time called adrenarche before we go through puberty, before we have our first period, where the adrenals activate stressors at this particular time. But we don't have any solid evidence to say that that is the cause. It's possible, but the evidence that we do have points more to the fetal development timing, because that is when the glands develop in a more primary sense. And so we know that, the adrenals develop then, so do the ovaries. We do see those timings. It's also possible that that could be happening at puberty too. And so there's some preliminary info, but it's definitely not conclusive. Like what you would see online where, some people are saying it's all from that. I would say it's very complicated and we don't really know.
Okay. Yeah, that's so hard about like social media has been great because there's so much awareness being created, but the challenge is that it's snippets because, we have our 30-second reel and, the quick picture and the quick quote, and we're in a quick fix society that probably got even worse when social media hit because everything has to be snippet. So I appreciate you adding
Yeah, this is a
that
question I
additional
get all the time
context.
because I've been posting a lot
So
about the
another question that
epigenetics.
came up since you
And
brought up
so the
epigenetics
top
is
thing to
many
think about
ask
with
if their
PCOS is
daughter
the
will get
genes
it
for PCOS
and
are
what someone can
primarily
do
genes
to
that give us certain
prevent it.
benefits.
So you did
So they're
mention it can
genes
happen
that
in
cause us to
utero, but
make
I
more
think people are
androgens, more
looking at, oh my
testosterone.
goodness, how will
But
I
the
know for
other
sure if
genes
I
that they
have
have
it, will my
linked
kid get it? And
to
then, oh my
not,
goodness, what
it's
can I
not a
do to make
genetic
sure they
disorder where
don't?
it's
So
directly
can you
inherited, but
maybe
there's genes that
expand on
like
that
increase
element?
the likelihood. So the other genes are conservation genes, metabolic conservation genes, which help us survive famines in times when we don't have enough food. So if you can imagine, there's really good reasons that we have those genes, and those genes actually make us stronger. So there's certain, people with PCOS I view as sort of genetic variants that have benefits. With the androgen excess, there's a lot of benefits to that in that there's increased survival in times of famine, increased muscle mass, later menopause, meaning that you can have babies a little later. There's other interesting theories around spacing of babies further apart increases survival. So it's all part of just the complexity and the mosaic of humans in general. So the first thing is, will my daughter have this? This is not necessarily bad. So this is just like a variation of people, where we have all these little variations. Some of these are good things. So androgen excess, there's been a lot of benefits to that. And we see a lot of the patients with PCOS do very well in athletics and sports. A lot of the young athletes have, who are very, very high level have PCOS. So there's those benefits. So your children will get those genes, anyway. Some of those are good, but the environment and the problems that it causes are what we want to look at. So obviously metabolic conservation, where we're great at storing energy. This is where insulin resistance comes from. Being great at storing energy is fantastic when we have famines. Being great at storing energy is not so good when we can go through the drive-through and fast food is 99 cents compared to fruits and vegetables. So it's like those impacts on those survivor genes are what set us up to gain a lot of abdominal fat. So it's that combination. And the other element is there are certain parts of the PCOS that are more problematic when they're younger, like the androgen excess. That decreases with age. So there's ways to manage it younger and then get the benefits later. So it's always like, how can we prevent it in our daughters? Well, some of it you can't prevent because some of it's genetic susceptibility, but the rest you can do so much about. So in utero, just eating healthfully, trying to do, as much as you can just to have a healthy lifestyle. But the androgen element isn't necessarily something that you can change that much when you're pregnant outside of insulin resistance. But when your daughter gets to, into childhood and getting them into some sports or seeing what kind of activities they enjoy, teaching them about healthy lifestyle, and then managing the androgen excess when it needs to be managed, all those things can be done and it's very possible to do them and still get, all those benefits of having PCOS at a little bit of an older age. We just see so many benefits of that. So, so I individual health in each situation. Yeah, so interestingly, we do know that androgens rescue follicles in their primordial state. They bring them up to the antral state. So the primordial state is a very tiny follicle that's really potentially could become a hormone
Okay, that
producing
makes a lot of
egg,
sense. I love
and
that.
androgens help
Now,
them get to
going
that
to the
point.
other end, because you were
As we
saying there
get
are benefits
older,
as we
all
age.
patients,
So,
their androgens start to go
interestingly, someone
down
had
quite a lot,
asked
actually.
you to
And
comment
that's
on
part of
PCOS
why it's
and
part of the whole process of
perimenopause.
what happens when we
So,
get
what
to
should we know
perimenopause.
about
We
that?
are running low on eggs, or the eggs are behaving differently. They ovulate earlier because of this difference in their behavior, and cycles get shorter. Androgens keep them going a little bit longer. And so what we'll tend to see is that perimenopause happens a little bit later. Like we'll see patients with PCOS having, normal length cycles instead of short cycles in their 40s, whereas they might have had long cycles earlier. Patients without PCOS generally start shortening their cycles in their late 30s, early 40s. So this is all delayed a little bit. And then the actual menopause is also delayed. So we do see like it's possible to have babies a little bit later. The age of menopause is a little bit later. It's also possible to gain more muscle mass in this age range, which can be challenging because of the androgens just help a lot with that. So yeah, we do see quite a few different benefits with aging, with having PCOS. So it's not all bad, that's for sure. So some studies have looked at that, and what they found is the hot flashes, there's no difference really. And then I would tend to agree with that. I tend to see those as variable from person to person. There's some patients who tend to have high estrogen before. Some patients with PCOS have that and some don't. So I find that isn't really that different. The other elements, similarly, I
Wow.
find
What
vary
about
from person
the
to
symptoms
person.
that tend to
But
come
the
with
insulin
perimenopause,
resistance part, where
like
the
the
weight
hot
gain around the
flashes and
midsection,
weight
that tends to
gain
be a little
and,
worse in PCOS because
migraine
androgens can
sometimes,
cause that type
different
of
mood
weight gain.
disorders? What are
There's
you seeing
also,
there?
when we lose estrogen entirely, there can be some more abdominal weight gain or change in where the fat lands, so to more around the midsection. And when you add that with the androgens, that can be a little worse in PCOS. But it is very individual. Like there's a lot of patients who don't have a lot of insulin resistance either. So it is something that just sort of needs a reassessment. No, it seems actually to be good, if anything, to hit menopause later because we just have a little bit of a longer exposure to the hormones that are beneficial for our bodies and bone density. Having children later, I think is really just it's still, our age still affects egg quality regardless, but the quantity of eggs is higher. So it just gives that little window. But again, I also don't want to make people think they should wait until, some of the celebrities you'll see having babies
Okay,
really
got it.
late are
Now,
using
is
using
it
egg donors.
bad
So it's not
that you can have
necessarily
children
true that,
later or
you can
that
just have
you
a baby
hit
at 48.
menopause
That's
later in
still really
life? Like,
hard and
I
almost
don't know if you have
impossible for
any
most
comments on
unless
that.
there's something else being done there. But yeah, like if you see a lot of patients in their early 40s, a lot of our PCOS patients do conceive, and I think that's totally good. It's a great thing, especially with life being so busy and it taking longer to get through everything before we are ready to have kids.
I know, no kidding. So what I thought we could do now is go through just a couple of areas that I think are important because, PCOS is
Yeah,
complex.
so
Generally,
autoimmune
healthcare is
thyroid disease is
complex,
about
and we
three
tend to
times more
get
common
treated
in
as if
PCOS
things are in
patients than in
silos.
other
So,
patients,
kind
and
of
it is one
going
of
with
the
this theme
most
of the
common
complexity, I wanted to
conditions
cover
generally that
thyroid
we see
conditions and
in women of
PCOS,
reproductive
as
age.
well as
So
the
having
gut
positive thyroid
microbiome. And I have a
antibodies,
special passion for the gut
this is
microbiome,
known,
especially
as
because the most recent
Hashimoto's.
podcast
We see this
episodes
a
I've been
lot, and
doing,
the
they're
problem with
about
that
a
is
specific topic, but
PCOS
like
is
the root cause of
inflammatory. It has a lot of
everything was the
inflammation,
gut
so it does lend to
microbiome.
other
And so I
inflammatory
have
conditions to develop because of that. And the other
especially
problem with thyroid
high
is if a
fascination with
patient
that
is
right now. So why don't
hypothyroid
we talk
even
about thyroid
slightly,
and
it
PCOS
adds
first?
into
Just like
all the
a quick
metabolic
summary of
problems in
things that
PCOS. So
people
those
should
two
be
really
aware
are
of. And again, you
important to
detailed
make sure,
in your book, but I think just
that's
any
checked for
high
anyone who
level
has
notes that you
PCOS
want
because of
people
the
to
impact it
at least
has, but
walk
also
away
the
with an
increased
initial
likelihood of
understanding.
it being there in the first place. Yeah, so I always do a full thyroid panel for my patients who have PCOS on the first visit if they haven't had one. And it's actually surprising how many people have never had that done. And then I think there's just a little delay. Yeah, no, you go ahead. Yeah.
Okay. Wow. Yeah, I've done a lot of thyroid episodes.
Yeah,
No, go ahead.
it's
Go
just a
ahead.
huge thing. It's so common. And then the other element I find
Is
is
there?
it really affects like thyroid, especially like
No, I
lipids and
was just going to
fatty
say I've done a
liver.
lot
And
of
it's just if the
interviews
person is on
with
the brink of getting
thyroid
insulin
experts and
resistance and then
even
they have
patients, and there is
hypothyroid, like they
so
will go
much to
there.
understand around the
So it's a
complexity.
really, you
And
want your thyroid to
in
be
your book
functioning
actually
very
did a beautiful
well
job
and
of
for it
laying
not
out
to
the different
have
types of
any,
tests
anything that's
that need to be
out
done
of,
and
the ideal
what
range,
all of those
just to make sure
different
that you're not
ones
struggling harder
mean,
than you
because you're
have
right, a
to
lot of people will just
with other
measure
elements of
the TSH.
PCOS.
And I also, when you look at symptoms of so many different conditions,
This is a really
there's
interesting
so many that
area.
are
So,
overlapping. And in this
yeah, so
case,
I
they
love that you're
genuinely
talking about
do.
how,
Like a lot of people
so many different
with thyroid,
conditions are
with
linked to
PCOS
this,
do have
and
thyroid
it's
conditions.
so
So,
true. And the
anything
same
else to
is
add there?
true for PCOS. They've actually done quite a bit of research into the microbiome. There's definitely differences. So we can see a huge change in the diversity. So there's a lot less diversity in the gut in PCOS. There's also, depending on the level of insulin resistance, there will be metabolic shifts. So we'll see a shift towards the types of bacteria that we'll tend to see in people with diabetes or insulin resistance. This is, in my opinion, related more so to the level of that's there. And they don't know what comes first. They're still trying to figure that out, but it seems like it's all, just part of the same net
Okay.
where it's a
And then what
cycle that
about the gut
keeps everything
microbiome in
going. The gut
PCOS?
keeps
Anything we need
the,
to know there?
the insulin resistance going and vice versa. And there's also some bacteria that have been associated with androgen excess, like Prevotella, that might have been found to be increased in PCOS as well. So yeah, so they're still looking at a lot of this and determining what's going on, but it's a big difference for in the gut microbiome in patients with PCOS and without. And they've also found the vaginal microbiome is different as well in patients with PCOS. So pretty interesting stuff.
Hmm. Interesting. Okay. Yeah, and I know that we understand the
Yeah, so I think
importance
one of the
of the gut
misconceptions around
microbiome and,
those
and
tests
having
is
this
that,
balanced or
you
optimized
do this test
gut
and
health,
a lot of these tests
but
are
it seems like
PCR.
there's
So
so
basically what
much
they're
still
picking
to
up is
understand to then know,
dead
okay,
DNA,
then
like
what do you
DNA
do?
from
I
dead
feel like
organisms. So it's
the
very,
research
very
is more
sensitive,
at, like, for
firstly.
example,
Can pick
you
up
can do
things that
stool
aren't
testing, and
necessarily a
an expert I
problem,
interviewed said, okay, the
fragments of
stool testing is
things,
great,
so it can be
but then what
misleading
do
in that
people
sort
do
of way.
about it? And
But I think one of the
apparently what
misconceptions
people are
is,
hoping
oh, if
for, and
you're
it seems
low
like
in
the
this, you
direction
will
it's
just
going,
take this
is once you do the
probiotic
stool
and it will
test,
just,
it will be, okay, these
replace what you
are
are
the
missing.
bacteria
But
that are
that's not
off
generally
balance.
how
As a result,
probiotics
here
work. So
is
they have
the
an
mix
influence
of
on the gut as
things
they
you should
pass
take.
through, but they don't just
Obviously,
like
diet
land there and
nutrition
start
too. This is
growing and
not a
change the whole
substitute
microbiome.
of eat
What we
McDonald's.
know
By the way,
about the
take this pill and
microbiome
now
is it's
you'll be
very
better.
complicated. It
But
starts,
I
there's
think
a lot of
there
different
will be a
factors in it.
lot more
A lot of it is related
unique
to
prescriptive
our
ways
even our
of
family
helping
history. What
people.
did we inherit
So I
from our
guess what can
parents?
people
But
do in the
also, like, what is
meantime?
the
Is it let's
state in
follow
our
your eight
body? What are
steps
we eating
and
that is
let's see
feeding
what the
those
research
bacteria?
shows for other
And,
things? Or
what
is there
is the overall
anything else that we
hormonal
should
status? So the
consider with
hormones in
this
our
gut
body
microbiome
affect our
knowledge?
microbiome. The immune system affects our microbiome. What we eat massively affects our microbiome. Toxins do. So it's really not as simple as taking something to fix it, replenish it, but more so learning over time, what are the factors that cause this shift in the microbiome in a human being? And then that's what we still need to learn more about. But we do know that food shifts the microbiome massively. So, for example, if someone were to eat a high sugar diet, their microbiome will become more like someone with insulin resistance, fault of something rather than the underlying cause. If you feed an organism what it likes, it will grow and it will make more babies. So there are certain organisms that like sugar. And so a lot of it is around that, like really understanding that whole idea. And not to say probiotics aren't good, they are great and they have a lot of health benefits, but it's just not as simple as that. It's really about understanding the entire person's physiology. And, even going back to those 8 steps, it's really about the foundations of health in anyone, is just like addressing all those things that we know help support health, and, a good gut health. So, for example, you could have a poor microbiome because, you're not making enough digestive enzymes to break your food down, and that's encouraging the wrong organisms to grow. So we want to look at the whole person's digestive process, their overall health, and that's really the best way to address it. So yeah, it's super interesting area. Yeah. Yeah, this is like a big one because there's a lot of division around, just nutrition
Okay.
communities generally about low carb
No, for sure.
diets.
Now, since you
And
brought up
so a lot of
sugar,
this has kind of come from that
so I know you
area,
put in
and that
there for
now, okay,
diet in your
carbs are either
book, the number
they're either
one thing
good
to
or they're
avoid for
bad,
those with
depending on
PCOS
what
is
kind of
sugar.
following,
But the
what
thing
you're
I
following.
did want to ask you
So I
about
don't view
is
them like this at
carbs.
all.
So,
But carbs do
again,
have the
because
capacity
of
to raise
social
our
media
blood
being
sugar
very quick
more
with
than
the
any
30
other
second,
macronutrients.
you know,
So
or the 2 second
because of
post or
that, we
whatever
want
people
to
are
make
putting
sure,
online, I think
because
we
anything that
can
raises our
make
blood
a
sugar
bigger
will
thing out of
raise our
something.
insulin.
So there's the
And
whole like carbs
unfortunately,
are
with
bad, carbs
PCOS,
are
sometimes
great.
patients
Eat
are
carbs when you want.
prone
Never eat
to
carbs. Only eat them at
hypoglycemia,
night. Like
where
I've
if they eat a lot
I've
of
heard it
carbs without
all.
proper balance
And you
with that
talked about
meal,
some
they'll get
really interesting
hypoglycemia. It sets them up to
indices
kind
that
of
we're
go
looking
on
at for
that
food, like
roller
the
coaster of blood
satiety.
sugar,
I
and
can't even say the word.
causes a lot of problems for
Satiety
them.
index, the
So
fullness factor, all
carbs,
of these
though,
others,
are
which
very
scores
beneficial, for
food
example,
in
for
a
the
way that I'd never seen
microbiome in the
before.
gut.
So it's
A
really
lot of the
cool. So
microbiome
talk to us
likes
about,
carbs to
I
eat,
don't know if you
and
want to talk
carbs are
about
also
carbs or
calming.
just
So
diet in general, just
I
like an
do recommend carbs
overview,
for
and you
patients with
detail it again in
PCOS,
your book, but
depending
just like an
on their
overview
level
on
of insulin
this whole
resistance.
carb
What I'll
food
generally do
debate
is,
with
show patients
PCOS.
how to create a balanced meal. What softens the blood sugar impact of carbs is proteins, fibers, and healthy fats. So if you combine the meals that way, the carbs don't have that abrupt effect on blood sugar. And generally, if someone were to have that once in a while without that, balancing effect, it wouldn't have an impact. So it's more about what you do most of the time with the carbs. Some people do much better on a moderately low carb diet, meaning that they're not eating a huge amount of carbs, but they're also not anywhere near keto. But everyone's a little different. So I think it has to be varied from person to person. One of the problems with really low carb, like keto, for example, a lot of people cannot sustain that long term. So it's something that will cause you to completely stop and then go back onto a different kind of approach, which may not work. So that's a big issue. The other thing is that it can cause insomnia for a lot of people because they don't have any way to keep their blood sugar stable while they're sleeping. Most of how we keep our blood sugar stable is through the glycogen storage in our liver, which is primarily put there by carbs. So when we're, having our dinner and that's our last meal for the day, our glycogen in our liver is what keeps our blood sugar from crashing while we sleep. So if you're on a really low carb diet where you're really having very few carbs, there's a low glycogen in the liver, and while you're sleeping, the blood sugar can go down. The way that we raise our blood sugar is by raising cortisol, and that can wake you up. So this is a common thing for people on keto. They start waking up at 3 or 4 a.m. That's not good for PCOS either, because we have lots of evidence that poor sleep, high cortisol, all of these things are problematic. So I think it's about finding that balance, something sustainable that keeps the blood sugar nice and stable long term. And carbs are definitely part of that. So, but I always look at everyone as different. And for some people, certain things just work for them. And that's great. I agree. 100%. Yeah. So this is a treatment that we use at the clinic with patients. So not a lot of clinics are using this, and this was, obviously developed by Dr. Jerry Lynn
Okay.
Pryor
No,
at
that makes sense.
UBC, and
And
through her many years of hard work
I've also
researching
seen,
this.
because I've tried all
It is
sorts of different
definitely what
things
I
to
find
stay
to be
healthy,
a
and I
really
find
helpful
the
tool to
experimentation
use
is
in
so important.
PCOS
That one
treatment.
size fits all
In
black and white
particular, it's
thinking, I
really
think is so
helpful
important.
for patients who
And I've
don't
also found
ovulate
for
regularly,
myself,
who
depending
ovulate
on
late,
other
or who have
factors in my life,
androgen
certain
excess.
things bother me more
And
than at
especially
other
for lean
times. So it's not
PCOS
even
patients, it's
a
quite
black and white
helpful
of
because
I can eat this,
for
I can't.
them,
Like,
they
for example,
often have a lot less
sometimes if I eat like
insulin
too much
resistance.
bread, I mean, I'm gluten-free
And
and
what
dairy-free,
you'll see,
but
or what I see in my
if I
practice,
eat
is a
bread
lot of the
too many
patients
days in a
coming to
row
me
for
with lean
breakfast, like my
PCOS,
avocado
they're
sandwich,
already
I just
doing
feel
like
so awful. So I
nutrition. Like
notice like
they're
I can
already,
do it, but it
some of
has
them
to be
are
less frequent.
restricting carbs and,
And then there's probably
it's
other
not
factors in my
helping
life,
them
so
at
who
all.
knows?
Like they're
But I
still just
appreciate you
having
sharing
the
that
exact
because,
same problems. And they're like, well,
again,
what
it's
else do I
great to
do
have all
now,
this
right?
awareness on
The
social
only other
media, but I
option that's
think we need
offered is
to
the
all
birth
take it
control
with a
pill.
grain of salt and
And
then go
so
to our
a lot of
doctors
the
and
time,
find
you
the right
know, this is
specialist
not
to
something
figure
they
out what
want to
actually
do.
works for us
It's
as
not
the
a stage they're
individual.
at. Maybe they want to conceive.
Um,
Maybe they want to
yeah,
ovulate, you know, maybe they
thank
can't
you.
tolerate the
So
pill.
then,
Maybe it's just something they're
medications.
not willing to take this,
So
you know,
one of the
to have the
questions
side
that
effects of.
one
Cyclic
of the experts
progesterone does not
actually that I
have
spoke
the
with wanted me
clotting
to talk to you
risks that
about is
birth control pills
cyclic
have. It does
progesterone.
not stop your ovulation like birth control pills, so it doesn't entirely replace your hormones. Your own natural hormones are still there. It's a little more
Hmm.
complex to implement clinically, so I would say that's the negative on it. It's just a little, it takes a bit more time to explain and help patients understand how to use it. But it's a really amazing tool that I use all the time in my practice, and it makes a huge impact on androgen levels, a hormone called LH that's often too high in PCOS. We usually see that coming down a lot with this treatment. So it's fantastic. Would you be able to repeat that because it just cut out? It is, if this is not taking time, it is quite clicky and it goes off. It goes silent as well. So, yeah. Yes. Oh, no problem. How? Yes. So it's the standard weight is from cycle day 14 to 27, and the studies are on 300 milligrams of oral micronized progesterone. This is not the same thing as synthetic progestin. This is the top confusing thing I get is that how is this different from doing Provera medroxyprogesterone to induce a bleed? This is a very different substance in the first place. It's the same exact progesterone our body makes after we ovulate. This dose is approximately the amount that would be there after ovulation. So this medication is really mimicking exactly what would happen in our natural cycle if we were ovulating. So yeah, that's the standard. I do also use different doses for certain people for other situations. For heavy periods, I might do a bit of a higher dose. And then if the patient was very sensitive, I've had a lot of success with doing low doses too. So metformin is probably the top medication prescribed for PCOS outside of the birth control pill. It has become almost like a standard prescription. It's used in diabetes medicine
And
to
when
improve
can you
insulin
explain a little bit
sensitivity. As a medication, it's
when
not
so
terribly risky compared to
the
other
cyclic
medications. Its side effects include
progesterone? So
primarily
what is like
loose
the
stools,
timing, just so
bloating,
people
but unfortunately, it
understand if they
also
wanted to talk to
isn't
their
that
doctor about it?
effective. Oh, let's start again. Unfortunately, it isn't all that effective if the patient. I'm
Sure.
back.
That was weird. I got a message that it said that our sound
I'm
is
having a
is
hard time
good.
recording.
I was like, oh my God, I'm so
Great.
nervous.
Oh
So
no.
I
Go
swear,
ahead
this is a bad and say that again. So I'm going to ask
I'm
the
done
question
using
just in case, and I'm going to tell them I'm running late to the meeting. So if I'm not looking at screen, I'm paying attention.
Oh, no
Okay.
problem.
So now when it comes to medication, I did also want to talk about berberine versus metformin. So can you tell us about that?
Yeah, metformin is a diabetes medication and it's used to increase insulin sensitivity, and it's got a lot of research for PCOS as well. It's
I'm so nervous.
generally given for
I
patients who have insulin resistance.
figure out what is
In
going
my
on,
opinion,
and I'll have to
it's not
contact
a very
Riverside and see if they
strong
can
medication
fix
to
all
help
this stuff.
PCOS. It has a mild effect.
Um,
It can have side effects like bloating, loose stools.
Nonetheless, because I hear on my
But
side
it really, I see a
my
lot of
headset
lean
is
patients
acting
being
strange,
given it, and it doesn't make that much of an impact for
and
them.
so I don't know why
Berberine is like
because
a
I'm plugged
herbal
in
alternative to
correctly, the
metformin.
way I'm always plugged
It
in.
is made from the berberine is in different types of plants. Golden seal is probably the
Um,
most famous plant that has berberine.
by the way, I have a
It's
meeting at 1
similar in the way
o'clock,
that
so
it
I'm
acts
trying to like
actually to metformin in that it improves
us
insulin
through this.
sensitivity. It changes
I
the gut
apologize. Like I
microbiome
normally
in a
use
way that's
a
very
half
similar
hour
to
free
metformin
after,
as
and
well.
I got a client
So
meeting
we
booked.
just
So
don't have,
um,
we don't see as many side effects with it. It can have some similar side effects, but a lot less than
progesterone.
metformin. But I kind of view them as, you
How
could,
do you dose it?
take
Can
one
you
or the
explain
other,
that a
and they
little
both
bit?
have a similar effect from what I see in patients, and studies show the same.
What about GI side effects? So I actually, I'm in the pharmaceutical industry by day, and I started out in sales, and actually metformin, at the time, glucophage, the branded product, was one of the drugs that I had actually sold. And I know that there's a ton of GI side effects, and I know if you titrate at the lower dose, start at the lower dose and titrate up, that often helps. Do you get the same with the berberine or no?
Yes, it's the same actually. It's just less, I find.
Okay.
But yeah, start low, go up slowly, or if someone starts on the full dose and they have side effects, they can go down and start slowly. But I also find those side effects go away, and same with metformin for a lot of people. Not everyone, but yeah, I find it to be very, very similar actually.
Okay, thank you. Now, we know mood disorders is another thing that PCOS patients tend to suffer with. And you had a really interesting point around why you may theorize that women have mood disorders if they have PCOS. And I think it was in your section where you were talking about Vitex and some research there that you had correlated. So, can you just address that?
Yeah, we see a lot of mood disorders in PCOS, ranging from anxiety, depression, and especially eating disorders are very common, especially bulimia and binge eating disorder. A lot of these effects are complex. So the androgens have definitely been associated to causing
Okay, thank
eating disorders, binge eating.
you for that.
It can be
Now, another
triggered by
interest, this is actually
androgens,
in your
and so
book, but
that's
I
a
do
big
think
part of things. The
worth
other problems that can
discussing
arise are
here.
because the hormones
Metformin
aren't
versus
quite
berberine.
balanced. They're not
Talk
doing
about
the smooth transitions they would normally
that.
do. We all know what PMS is like. That's when your hormones are crashing, from high to low at the end of the cycle. So in PCOS, there's a lot of things that happen like that, where the hormones attempt to go up and then they go down, and it's unpredictable. So that's not a very nice thing for the brain to experience. So there is that element. We also have low levels of hormones like progesterone, and in some patients, they have low estrogen too. This is a misunderstanding that everyone has high estrogen. It's not the case. Some have actually low estrogen, which is required for mood. Secondly, there's a lot of inflammation. So inflammation has been linked over and over again to mood disorders like depression and anxiety. So that's definitely involved, I would say. And then blood sugar dysregulation. It really affects mood a lot. It can affect cortisol, as I mentioned before, sleep, all sorts of different things. And then having PCOS is stressful. So there's social stigmas around having those symptoms of hair growth on your face. Your hair is falling out. You have acne. You're not getting your periods. You can't get pregnant. You go to the doctor and they dismiss you. All those things are very stressful and challenging emotionally. So there's a whole bunch of different ways that it can affect mood.
Okay, wow. Thank you for sharing that. And again, I think the theme here is it's all complex and you really have to look at the individual. So then now in conclusion, like we take your 8 steps and we take all the wisdom you shared and we follow it and we're doing great. Can you actually cure PCOS?
Well, you can't. So it's one of those things that is sort of there, and a lot of it's genetic, and then there's epigenetic influences. So you cannot eliminate PCOS, but what you can do is manage the symptoms and reverse the symptoms to the best that is possible in your body. And not everyone may be able to entirely reverse their symptoms. For someone who's had insulin resistance for 20 years, that's a very different situation than somebody who's had it for 2 years. So it's always individual, and a lot of things can be reversed. I like to use that word because it's, the condition and the predisposition is still there, but the symptoms can be managed and, handled throughout different phases of life. So yeah, although it cannot be cured, some of those genes we don't want to cure. They're kind of good for us, but the parts that are problems we manage in different ways at different times of life. So a lot of it, you can go through and your life and have no symptoms at all if you find treatments that work for you for PCOS.
Wow. Well, I know my takeaway from this is all the women out there who do have this condition should have hope. Like you've provide that it's hard, it's complex. You got to take your time, figure out what works for you. And but I definitely, hope people take away from this that there is hope. What would be your takeaway that you would want women to have in listening to this episode?
Yeah, I think the most important thing is focus on the strengths that it gives you and not so much on it being only a negative thing. It really is a genetic variation that their environment is not really conducive to supporting. So try and look at the positives and don't get too focused on some of the fear that you'll read online because A lot of the times when you read these things, people are trying to sell you something to do that. So really like dig into things that you're reading and just make sure before you believe something that's making you feel anxious or worried that it's coming from a legitimate source. But yeah, like there is so much you can do. Have hope because every single element of this can be really well managed. So just like keeping your, looking at that as something that has good and bad things to it, just like anything else. And knowing that there's a lot that you can do. So yeah, don't let anything get you down that you might be reading online, especially these days.
Yeah. Wow. This was even more amazing. I knew it was going to be an amazing discussion, but even more amazing than I could have ever imagined. And so I really appreciate your dedication to this area. I appreciate that you've written this book. And for those listening, there are so many resources in your book and on your website, and obviously the book itself. And so I'm going to put all of that in my show notes and where people can follow you on social media. But Fiona, truly, thank you. I'm so glad that Lara Bryden introduced us. So thank you, Lara, for that, and Dr. Pryor as well for all your work. Great discussion, and keep at it. And I hope that everyone took away such great things out of today.
Thank you so much, Georgie, for making this awesome podcast and for inviting me. I'm
This was
super
great.
excited to just see where you go with it.